So thanks again for joining us for this timely, important conversation on Medicaid changes following the recent passage of the budget bill signed in July. My name is Lara Salahi, AHCJ's Health Leader for Health Equity. I'm joined by Joe Burns, who writes about health policy and health insurance for AHCJ. We're going to be your hosts for this conversation. Whether you're covering health policy at the national level or reporting in your own community, today's discussion is designed to help you better understand and better report on the massive changes that are underway in Medicaid. These changes are already reshaping access to care across the country. They have immediate and long-term implications for individuals, for families, and really entire communities. Many of us have and will continue to report these stories, so it's so critical that we understand not just the policy shifts, but also how those shifts are playing out in real people's lives, which, by the way, AHCJ is exploring several topics related to the budget law at the annual Rural Health Workshop on August 21st in Atlanta. So check out AHCJ's newsletter for more information, and it'll be live streamed for those who can't make it to Atlanta to be there in person. But today, we're thrilled to be joined by three exceptional panelists: Kathy Hempstead, a senior policy expert at the Robert Wood Johnson Foundation, who brings deep insight into Medicaid trends, coverage transitions, and the policy landscape. We've got Joanne Kenen, contributing writer for Politico Magazine and journalist in residence at the Johns Hopkins Bloomberg School of Public Health. She has long covered the intersection of health policy and politics and brings a sharp journalist's lens to these complex issues. And Kristen Shamus, a award-winning reporter covering healthcare for the Detroit Free Press, whose recent reporting is focused on the impact of Medicaid cuts in Michigan. We're going to begin with about 40 minutes of remarks and discussion, covering what's changing in Medicaid, where the biggest reporting opportunities lie, and how to make sense of the policy through storytelling. And then we're going to shift to 20 minutes of sort of Q&A, where we're going to take your questions. So feel free to put those questions in the Q&A space at any point during the webinar. We'll be selecting several to pose to our panelists towards the end. So it's been a few weeks since the bill was signed into law, and we've seen many stories about the number of people who will lose Medicaid, SNAP benefits, as well as access to health insurance through the Affordable Care Act. It's an enormous piece of legislation. It's got far-reaching implications, so we're going to dive right in. So Kathy, let's start with you.
Thank you very much. Hello, everybody. Good afternoon. I'm looking forward to talking a little bit about how I think journalists might think about some of the ways to cover this story. And I know today we're just really focusing on the Medicaid aspects, but as was kind of mentioned in the header, it's a big bill with a lot of other implications. You can go to the next slide. Thank you. I decided to chunk the topics up into a few different buckets that I think sort of parse out the different storylines and angles with the bill. So I think about sort of the magnitude of the bill, the timeline over which different parts of it are coming into play. I don't know, is no one seeing the slides? I just saw something in there.
Not yet.
Oh, okay. Well, while they're coming up, the first slide just showed sort of 6 buckets that I kind of parsed out for the conversation: the sort of the size of the bill, the timeline of the different impacts, the groups that are most important, sort of to think about who's affected the most, how different organizations and entities and people are talking about minimizing coverage loss or quote unquote sort of harm reduction, in thinking about, steps that can be taken to reduce some of the projected coverage loss, how states are reacting, and what kind of pushback is emerging. So it's a combination of sort of state and federal reactions to the bill. So I don't know if the slides are up yet, so I'm just gonna move along though. Okay, so now I'm on a slide called magnitude. And, as was mentioned at the top, this bill is really historic and unprecedented, both in its size, but also really in the nature of the cuts it makes to the Medicaid program. I'm sure you've seen the estimate that, over 10 years, it's going to eliminate $1 trillion in federal spending from Medicaid. And it also has a lot of really unprecedented kinds of reforms, work requirements, an increased frequency of eligibility determinations, imposing cost sharing on enrollees. These are all things that states have kind of experimented with in very limited ways or wanted to experiment with in the past, but this is the first time we're really seeing this at the federal level. Some really important restrictions on the ways that states can finance the Medicaid program, and some very specific anti-immigrant measures that restrict coverage for immigrants. And as was mentioned on top, I mean, even though we're going to talk about Medicaid today, it's important to keep in mind that some of these coverage impacts, there's a pretty big pile-on effect, because the bill also has a lot of provisions directed at the ACA marketplace that are going to affect enrollment. And at the same time, the expiration of the enhanced premium tax credits is also projected to have a major impact on coverage. So sort of all in, CBO is estimating that something like 17 million people could newly become uninsured over the next 10 years. So that is, depending on how you measure, between a 40 to 50% increase in the uninsured rate, and so that's massive. So many people look at this as, tantamount to, something very close to a kind of repeal of the ACA by pieces, or putting us back, significantly back on a, from a path that we've been on over the last, decade or so to reduce the uninsurance rate, and taking a major step backwards. So some of the things that you might think about that are going to happen as a result of Medicaid cuts, there's sort of a compounding or a pile-on effect in terms of the impact on providers, or the rise in demand for uncompensated care and things like that, because people are also losing coverage from the marketplace. So I would go to the next slide. Is that okay? Are the slides up now?
I can't get them. I can't access them. I'm sorry. There's something wrong with the internet in my office this morning, so I apologize.
Worries. I will just talk through them, and I could always share them later if anybody was interested. So they, one of the things I wanted to mention that reporters there's a lot of details in this bill, and it's, there are a lot of moving pieces. And so one thing I think that reporters want to think about is understanding the basic timeline. And a lot of the kind of major Medicaid provisions are not going to go into effect right away. The restriction on immigrant eligibility will be relatively soon, in October of 2026. But the major reforms that affect both the work requirements and people's eligibility redetermination won't go into effect until January of 2027, although a few states are interested in trying to start the work requirements sooner, but many states actually, on the other hand, may apply for an up to 2-year extension if they can demonstrate that they're making a good faith effort. And we right now don't have a lot of information about what that process would look like, what kinds of factors would be considered. And some of the changes in provider taxes and the wind down in the state-directed payments starts a little bit later. And on the slide, I have some links to some really good trackers that you might want to look at to sort of see when the different parts of this bill are going to really come online. But just because it seems like a long time from now, October 2027, that it's actually a very fast march for states to get ready for some of these reforms. So you're going to definitely be hearing about it much sooner than that. So the next thing I wanted to talk about was thinking about, sort of as you're covering this, what are the groups that are going to be most affected? So who are like the characters in the story that you're going to be telling? And believe me, it's going to be many stories. This was kind of breaking news for a while as it was going through Congress and getting signed by the president, but now it's going to be, just a multi-year story with lots of different things to talk about. But one of the things I wanted to just sort of, key up here are thinking about who are the groups that are really most affected from a Medicaid perspective by this bill. And one of them is the expansion population. So if you're working in a state that expanded Medicaid, then that expansion population is the population that's going to be subjected to the work requirements and subjected to the enhanced eligibility redetermination. If you're in a state that didn't expand Medicaid, these things are not going to be important to you. But the expansion population is the population that's really at risk for major coverage loss. And nationally, CBO estimates 4.8 million of the expansion population is projected to lose coverage due to work requirements. And, as I'm sure you've heard a lot of times, the idea really behind that is that the vast majority of those people actually will still be eligible, but it will be the, administrative complexity of complying with the work requirements that's going to make people lose coverage. Another affected group is immigrants. As on the slide, I have some details about like who's in and who's out that I can share later, but there are going to be a lot of lawfully present immigrants who are no longer going to be eligible for Medicaid. And so depending on, where you live and who those populations are and how important that is, that's potentially going to be something that you're going to want to write about and look into, and what are the implications for those populations. Another population that you might not think of at first, but actually is really important, is the aged and disabled, which is a group, you can sort of think about it in two ways. I mean, you can think about sort of people in the expansion population. A lot of them are older and a lot of them have disabilities, not disabilities of the level that make them categorically eligible for Medicaid due to a disability, but disabilities that make it difficult for them to work. So this is a population that many people think is going to be very vulnerable to losing coverage due to the work requirements. So that's one way that you can think about that, sort of centering on the aged and disabled. But the other way I want you to be thinking about it too is that, in Medicaid, there are, different eligibility groups, and one category, and it's a lot of times what people call the categorically eligible Medicaid population, is like the aged, blind, and disabled. And so these are people that have intellectual disabilities, very significant physical disabilities, and low-income seniors who rely on Medicaid for sometimes for medical care, but significantly for home and community-based services, like home health aides, like adult day programs, like medical transportation, like all kinds of things that make life possible and really can enhance the quality of life very much for these populations and for their family members who are often their caregivers. And one of the really important things to know is that a lot of these services in the Medicaid program are kind of discretionary. So it's not required that states provide these services to a certain extent. So as you probably know, if you've been covering healthcare for a long time, in many states, there are waiting lists for certain kinds of home and community-based services, or problems staffing adult day centers, or problems with, very low wages paid to people that work with these populations. So there's already a supply problem with these services, and there's, much more demand than supply, I'd say, in every state, some worse than others. But I think that when we think about these cuts coming from this bill, I mean, there's a set of reforms that are going to make people lose coverage, like the work requirements and the enhanced eligibility determination. But there's also these cuts to the finance mechanisms, the provider taxes and the state-directed payments that are just going to take money out of Medicaid. And the impact of that is going to be that Medicaid programs are, to varying extents, going to be looking around for ways to cut spending. And that is going to create a vulnerability for the categorically eligible aged and disabled population of, sort of losing access to services, quality of services, increased waiting for services. So, in this slide, I had a really great article, a link to an article from a paper in Tennessee that was about, somebody with severe disabilities, physical disabilities, that relies on the Medicaid program very much for a whole suite of services that allows him to get to work and be productive and do all the things and stay alive, in fact. And, great concern that access to these services is jeopardized by this bill. So I think that that's a really good storyline. And even though this population is not directly targeted, they're indirectly targeted by this law. Another group that I think is a very affected group that's certainly been very vocal is health providers, especially hospitals, who are going to, lose a lot of financing due to the, due both to the loss of insured people, and also because of the financing changes that are going to reduce state payments to healthcare providers. And they're going to see a big increase in demands for uncompensated care. And, there's lots of estimates, some of which we've funded from the Urban Institute, that really sort of go into that on a state-by-state basis. So if anybody wants to, follow up later, I can direct you to resources. Some of them came out before the final version of the bill passed, but, they're still, pretty good guide. And I think there'll be some updates too. So, there's definitely a vulnerability for hospitals. And the final affected group I just call out, and it's already been mentioned, is rural communities, because a lot of this stuff is kind of, intensified in rural communities because there's more reliance on public coverage. There's fewer hospitals. So if you see a hospital close, it has, really huge consequences for, for a community, which may then people have to drive very far to get to the next facility. So there's a lot of sort of ripple effects that are really, accentuated in rural communities. So I will go to the next slide now. An important and interesting angle, I think, is what we call to ourselves, at least, and many call harm reduction, which is really a term from substance abuse treatment. But we, in the context of thinking about these reforms, I think if you've been following the conversation about work requirements and eligibility redetermination, there's been lots and lots of talk about how, people really lose coverage because, not because they're not eligible, but because the process of documenting your eligibility is very onerous, and people have, multiple employers, or they don't have access to the internet, or they take care of their child 3 days a week, but they're not able to show it, or, all these different things that make it very hard for people to document that they're still eligible for coverage. So not surprisingly, there's a big effort taking shape to try to see if states can devise ways to sort of improve the accuracy, the accuracy of the process by which people are documenting their eligibility, so that we can reduce sort of erroneous coverage loss, or kind of improve the performance. Because, the fact that so much of the coverage loss is really not because of the lack of eligibility, but because of, administrative hurdles, suggests that there's an opportunity for improvement. So you will see, in every state, and this, if you covered the redetermination story, I think there's a lot of echoes of that, but you'll see different people coming forward. There's a lot of course, kind of tech companies and private sector types that have algorithms or want to use AI or have these different ideas. There's, talk about linking data in different ways, and it, plays out a little bit differently in every state. And, we still don't know exactly, what CMS is going to require states to do or how to do it. CMS has actually made some comments about trying to use technology and make some technology publicly available to all states to simplify the process. But I think that harm reduction is a really interesting storyline, and sort of gets into, kind of the advantages and disadvantages of using AI and using more technology, because on the one hand, it could reduce a lot of errors, and it also can introduce a lot of errors. And it's, it brings up some of the same kind of things that come up when people talk about prior auth and use of AI there. But I think that that's going to be a really important part of the story. So that's another one to follow. So the next, I'm getting close to the end of my slides now. So the next one I wanted to mention as a thing to follow is sort of how are states going to react. So I know I'm talking to people that are state reporters or local reporters, and people that are national reporters. But if you're in a state, and even if you want to talk about states, I think that is a great a great way to talk about the story, because you're going to see a big range of reactions, both politically and fiscally. You're going to see that some states are, maybe all of their delegation voted for this bill, and the governor is, not going to say too much against it. And there are a few states that are actually trying to jumpstart the work requirements and some of the other reforms, and then you're going to see other states that are very opposed to the bill, and all their delegation voted against it, and they they disagree with a lot of it. And some states are going to be more fiscally exposed than others. So as I mentioned before, states that have an expansion population, they have kind of more at stake than states that don't. States that have a lot of immigrants are going to have more issues than states that don't. Some states have become more dependent on provider taxes than others, so that's going to be an issue too. And rural states, of course, have a lot more to worry about. But what I'll say to you, though, is all states are going to be very fiscally pressured by this bill, whether they complain a lot about it or not, and whether they're on the more exposed or less exposed side. This is a very major piece of legislation that shifts a lot of fiscal burden to states. So you're going to see a lot of inside state conversations about how to deal with this. You may see states making cuts to services for the aged and disabled within the Medicaid program, and you may see a lot of complaints about that, and you may see a lot of local stories about that, and stories about how the quality of people's lives are being impacted by that. You may see conversations about how states might need to cut other things and or raise additional revenue to try to fill the gap that's been created by this bill. And, many states are holding emergency legislative sessions this summer to sort of talk about how to react to the impact of this bill. And as an example, my next slide, are my slides up? Are they still not up? No. Okay, so I'm almost done. But as an example, I wanted to show you some results or some examples of sort of state reactions in New Jersey, which is the state where I live and a state, that I follow pretty closely. And so New Jersey, of course, is a blue state. We did have 3 members of our House delegation vote for the bill. But in general, the governor's a Democrat, and we've expanded Medicaid. We have covered children, regardless of immigrant status, up to, I think, age 8. And there's been a very strong kind of negative reaction to the bill. The Medicaid agency put out really a very thorough report that obviously done some analysis and looked at some other studies where they talked about how many people they thought were going to lose Medicaid and how many billions of dollars were coming out of the state, health budget, and all of the consequences of the bill. Then the governor signed an executive order that directed every state agency to complete a report by November 15th, detailing, the impact of this bill on them, because obviously the impacts go beyond health. And so that would be, there's some version of this going on in every state. So that's clearly a good thing to follow. And these reports will come in. And then, just a few days ago, there was an op-ed in a state paper from a sort of consumer activist who was talking about, what are some ways that the state can fill the gap, and making some suggestions that, the governor's property tax abatement program should be changed, and the eligibility of it should be reduced so that we retained more revenues, and a number of other recommendations about things that the state should do, and in this person's opinion, to have more revenue at hand to offset some of these federal cuts. So I think you're going to see versions of that going on in every state, and they'll have different flavors in different places. But I think that that's a really good part of the story to cover too. And so finally, I wanted to get to the issue of pushback. I mean, of course, this is a bill that isn't popular from a polling perspective, and there's lots of states where it's very unpopular. I mean, I think if you follow Congress, you've seen Senator Hawley introduce legislation to repeal parts of it, even though he had just voted for it, to repeal the provider tax portion and the state directed payment portion, but keep the work requirements. Democrats have introduced bills to repeal all of the, healthcare cuts in the bill. Hospitals are lobbying furiously to delay or get rid of some of the, the provisions that really affect them. And it's worth remembering that the Cadillac tax, in the ACA was never implemented because of, interest group lobbying that just sort of indefinitely pushed it off, and then finally just got, eliminated. There is a $50 billion rural hospital fund that was sort of thrown out as a way to partially offset the expected impact of this bill in rural areas. So there's going to be a little bit of a scrum to apply for those funds, and there's going to be there's already a lot of criticism of sort of the process through which the money's being allocated. So that will be something to follow. And the other thing to say is that the midterms are going to occur before a lot of these things get implemented, and it will be interesting to see how much how much of this is coming up in races. And I did have a picture from an article on my last slide that again was a New Jersey example, and it was people like protesting outside the office of Congressman Jeff Van Drew, who is a New Jersey congressman who actually transitioned from being a Democrat to being a Republican over the last several years, and made a lot of noises about being very concerned about the bill, but then voted for it. And outside of his office were a lot of people. And, if you know New Jersey, South Jersey is pretty rural for New Jersey, and has had a lot of issues with substance abuse. And there were a lot of people at this protest who, had stories along the lines of, I got through recovery because I was able to have Medicaid. If I didn't have Medicaid, I would be dead. And, Medicaid saved my life, and et cetera, et cetera. And it was, it was a pretty spirited protest, and he's already gotten quite a few people interested in running against him. So it remains to be seen to what extent this is a really potent issue in the midterms, but it's I think that's a good example, and certainly that's a good thing to cover. So that was actually my last slide. Thank you very much, and I left my email at the bottom, but I know you can all feel free to contact me if you want to follow up on any of those things. So thank you.
Great, Kathy.
Thank you,
so
Kathy.
much. And we apologize that we didn't have the slides up, but we will. When this recording is posted, we'll have your slides up along with it for all.
Sure hope so.
Appreciate that. Kristen, over to you.
Thanks so much. I really appreciate it. It looks like we've got the slides up this time, so that's great. Thank you for your help, Joe and Lara. Okay, so when we talk about this law and what it means, we can definitely take a look at this national policy and figure out how it applies to our local states, our local communities, and the people who live in them. And it's really important when we consider this policy to think about how it'll touch people's lives and to get to the impact on a truly human level. And so that begins with really understanding the law and getting through the partisan rhetoric, because there's a ton of it, and trying to find balanced and accurate information in unbiased expert sources. And you can do that by seeking analysis and data from nonpartisan state and national public policy organizations. For that context, places like the Kaiser Family Foundation, the Brookings Institution, the Robert Wood Johnson Foundation. In Michigan, we have groups like the Citizens Research Council and the Michigan League for Public Policy that have been incredibly helpful to me. And your states probably have similar groups that can share local data and analyses. It's also a really good idea to seek out experts from research universities whose work focuses on that social, economic, and health impact of public policy. We have a lot of them at the University of Michigan who can provide that insight, not just on the national level, but on the state and local levels too. And Georgetown University, for example, and there's a link on my last slide to it, they have broken down county level data for Medicaid enrollment by population for the entire state, entire country. So it's really helpful when you're trying to figure out which communities in your state could be most heavily hit by Medicaid cuts, to look at the populations and see where you have the highest number of folks on Medicaid in your state. And as an aside, the communications director at Georgetown, Kathy Hope, she said we can use their maps with our news stories on our website. So all you have to do is email her and I can get you that contact info. I also really recommend contacting your state association for local public health, the state's hospital association, state nursing home care associations too, for additional context. If we can go to the next slide. Perfect. It's really key, I think, when it comes to getting readers to care about our work, to connect with real people and let the real people help tell your stories. And it's a little tricky sometimes when you're talking about policy stories to find real people to center in your coverage. And one way to do that, I mean, obviously you're not going to do man on the street for this kind of work, but what you can do is turn to advocacy organizations, nonprofits, and foundations to find the families who are most affected. So you could call, for example, your Down Syndrome Association in your state, or your Alzheimer's Association, or groups tied to cancer care or other chronic diseases, mental health. And many of them work directly with those families and help them find resources and support. And a lot of times that is how I find people for stories on all sorts of topics. We also know that federally qualified health centers might be squeezed as these cuts land. So think about calling your FQHCs, especially those that serve immigrant communities in your area, and ask how it'll affect the people they serve. And ask if there are local families who rely on their services who might be willing to talk with you. Call your sources at local hospitals. They might know of patients who will consent and talk on the topic. But ask everybody you interview, when you think about this problem, who will be most affected by it and how will it touch them? And is there someone you know who springs to mind that I should talk to, and could you connect me with them? That's a great tip. If we move on to the next slide, I can tell you about someone whose story I told in my coverage of this bill. His name is George Johnson. And look at that smile on his face. He's 6 years old and he lives in Warren, Michigan. And he has a host of medical conditions that are associated with Down syndrome. His mom, Taylor Johnson, told me that George has been wonderfully supported by a Medicaid expansion program in Michigan called My Child. And it covers his visits to about a dozen specialists, physical therapy. He has low tone in his muscle tone in his feet. He has speech therapy because he's mostly nonverbal. It covers his diapers because George isn't potty trained. And at age 6, the family just can't go to the store and buy diapers that'll fit him. And so his family was really struck by the changes that might come with the administration, the new administration, when the Office of Management and Budget Director ordered a freeze on federal grants, loans, and other financial assistance programs in late January. You might remember that day because the freeze temporarily brought down Medicaid reimbursement portals in all 50 states, and there was a lot of panic. It just so happened that George's diaper order was supposed to be renewed on that day. And because the portal was down, his order was denied. And Taylor was talking about how that started a panic in the family, and she feared that it might be the first in a series of dominoes that'll fall when it comes to George's Medicaid coverage. And she was trying to figure out what to do if the entire framework of his healthcare unraveled. And in the end, George did get his diapers, but whether he'll continue to be covered by My Child remains up in the air for now. And if you go to the next slide, we'll talk about something else too, and it's that George isn't their only concern when it comes to healthcare coverage for this family. The rest of the family buys an ACA marketplace plan that they get from the exchange. And the subsidies that lower premiums for people who buy their insurance through the marketplace were lost through this legislation. So it means premiums are expected to rise dramatically in 2026 and drive up the ranks of the uninsured. My Free Press colleague, JC Reindl, just wrote about how health insurance plans are seeking approval from regulators in Michigan for double-digit rate increases for 2026. They'll average about 16.8% for individual policies, including those sold on healthcare.gov. So those are stories that you can do in your local markets too, and explain to people exactly what all of this means to them in dollars and cents. If we go to the next slide, that'd be great. Thanks. I just saw something about my audio being lower. Can everybody hear me okay? We doing all right?
Okay. A little better now.
Okay.
Thank you.
Great. All right. So when we think about vulnerable people, let's think about people who live in long-term care facilities, nursing homes, and how they'll be affected in the fallout. Nursing home care is really expensive. It can cost as much as $10,000 or more in some areas. And because of the cuts to Medicaid, we could see some older people, some people with disabilities who previously qualified, they may be bumped off the rolls. And if they lose Medicaid coverage, they might not be able to pay that hefty price tag to stay in a nursing home. So think about what that might mean for families if maybe grandma who needs around-the-clock care suddenly has to move back home. I dug into that idea with the story of the Callahan family. You can see Megan Callahan there with her mom in the nursing home where she lives. And Megan lives in Shelby Township, Michigan. She's a counselor at a local community college. She and her husband have lived in Michigan for 15 years. He works for one of the automotive companies. And Colleen Callahan, her mom, lives in Wisconsin, and she's got advanced dementia. For a long time, Colleen's husband was able to take care of her, but now she needs 24-hour care and he can't manage it anymore. So the family applied for a Medicaid program called the Spousal Impoverishment Program, and that will allow Megan's dad to keep the home he owns, but it would also still allow Colleen to qualify for Medicaid to cover her long-term care. And the family's really worried right now because there's so much uncertainty about how that program will be affected, whether Colleen will still be eligible. And Megan's worried that she and her husband might have to quit their jobs, move back to Wisconsin to care for her mom. And there are thousands of other families like them across the US who are worried right now. And you can find them in your state too by calling the nursing homes in your area, the State Nursing Home Association, and ask to talk to families. There's another thing to consider when we report on nursing homes. And if you wouldn't mind just flipping to the next slide, that'd be great. At least a quarter of US nursing homes could be forced to close because of the cuts to Medicaid. Or if they can afford to stay open, they might have to reduce staffing or cut programming to trim their budgets, which could affect the quality of care. The American Healthcare Association, which represents more than 15,000 long-term care facilities, suggests that this is pretty significant. More than a quarter could have to close. And so these are questions that you can ask when you call the nursing homes in your community and see what you can find out about the local impact. If we move on to the next slide, we can talk about other things to consider when you're looking at state and local coverage. Think about the rural hospital crunch. I know Kathy mentioned a lot about this, but rural hospitals are expected to be under especially heavy financial strain as a result of this legislation. They operate on thin margins already. They have a higher percentage of patients who typically use Medicaid, and they have a lower volume of patients. So it's harder for them to keep their doors open and pay the bills. There is that rural health fund in the reconciliation bill, that $50 billion. It's supposed to soften the blow to rural healthcare. It stipulates that CMS will distribute an equal share of $25 million to each state, quote, with an approved application, according to the Kaiser Family Foundation. The remaining $25 million, CMS is going to distribute using its own discretion. So it's really unclear how all that's going to work, but consider the inequities that are possible here. KFF reported that in a state like Connecticut, which has just 3 hospitals that meet the definition of rural, they would get the same chunk if their application is approved of that $25 billion as a state like Kansas, which has 90 rural hospitals. So there's a huge opportunity here to figure out whether your state has applied and how much it might get and how that money will be distributed. And also look for something else too, hospital consolidations. Here in Michigan, we've had a huge trend of hospitals being bought up, merged, sold, consolidated in various ways with joint ventures. We could see that continue all over the country as the smaller independent hospitals no longer can go on their own, and they end up either closing or consolidating. And consolidation in healthcare, when we think about that with hospitals and hospital systems, it usually means less competition, which drives up prices for consumers and also reduces the quality of care. So there's potential.
Hey, Kristen, can I just ask a question? I'm sorry to cut in, but when you and I spoke the other day, we were talking about rural hospitals. And I think I mentioned that the Trade-Offs podcast people did a story earlier this week or late last week called "A Rural Hospital in Kentucky Prepares for Medicaid Losses." And it was really good. And they mentioned in there that there's a report from the University of North Carolina that says 340 hospitals will close nationwide. And it broke it down by state. And they picked this hospital in Kentucky, this rural hospital in Kentucky, because it was one of the 35 that is at risk. One of the 35 there's 35 in Kentucky, making Kentucky the most vulnerable state for hospital closures. And they picked this one hospital because they're facing cuts. So I know you and I talked about that, and I'll put the link up in the chat. So I'm sorry to interrupt. So go right ahead.
Fantastic. Thanks a lot, Joe. Appreciate that context. Okay, so if we can go to the next slide, you'll see some ideas for other stories that are just waiting for us to tell them. And I think it's really important for us to try to do that if we can in our communities, to serve our readers and to help people understand truly what the impacts might be. And Kathy mentioned the issue of home healthcare cuts. The University of Pennsylvania predicts that that could be one of the things that's on the chopping block first, that gets cut first by states. So look for that and how that hurts people without access to transportation, people with disabilities, people who live in remote parts of the U.S. who have a long distance to travel for healthcare. I mean, equity is the big issue there. And also look at your state budgets. We're in the budget process right now in Michigan. The state legislature is trying to settle on 2026 state budget. And there's a chance that state budgets could somewhat blunt the blow and the effects of this legislation. It'd be a really good story for you to take a look at how your state is approaching this problem, how much of the shortfall they can accommodate and make up for, what programs are likely to die, what programs are likely to survive, and who gets hurt most by it. And then also look at hospital service line reductions. This budget squeeze means that hospitals are likely to cut service lines to save money, and labor and delivery units are usually a casualty in that, especially in rural areas where the volume of deliveries is lower and, again, higher number of Medicaid patients. When they cut this service, think about what it means not just to people having babies, but also to that region and that community. If there's no hospital with a labor and delivery unit, is an OBGYN going to stay in that area? If the OBGYNs in that area leave, who provides all gynecological care for all the people in that region? And what does that mean for infant maternal mortality? What does it mean for prenatal screenings? What does it mean for STDs and cancer screenings in that area? And if you go to the next slide.
Can I just add, before you go on, Kristen, can I just add that the Trade-Offs people, we're talking about Harris Memorial Hospital in Cynthiana, Kentucky, and the chief of strategy there was concerned that they had to cut labor and delivery, just as you said, and cardiac care. So they were talking about, hearts and babies. Both of those services might be cut, which was a big concern to the hospital administrator. So I just wanted to add that. Thank you. Sorry to interrupt again.
No, absolutely. It's good context. Okay, and then if you look here, I've got a bunch of links here that might be helpful to you, and also how to contact me if you want to talk through it or have any questions later on. Thank you.
Thank you, Kristen.
Wonderful. Thanks so much, Kristen. And Joanne. You're muted, Joanne.
Joanne, you're muted. I might have her text. I can text her.
Joanne, can you unmute yourself, please?
Go like this. Joanne, we can't hear.
Somebody else had muted me, so I couldn't unmute. So now I'm unmuted. Okay. I'm going to talk pretty briefly because we're running out of time, and I wanted to talk a little bit about the history of Medicaid and and how that shaped the politics of Medicaid. It was passed the same, this as part of the Medicare back in 1965. They were signed into law the same day, and yet it was a very, very, very small program. It was not a particularly popular program. It was limited to a very small population of very poor people. That's very different from now. Enrollment goes up and down. It fluctuates with basically with the economy. But right now there are somewhere between 70 and 80 million. It has peaked a couple of years ago during the pandemic. It was 90 million. Right. So it's 80-ish. It's around 80 million people. And as it changed over the years, as it got bigger and incorporated more and more populations and services, naturally, as the services and coverage got bigger, the political constituency got bigger too. You can't have 80 million people covered without sort of ripple effects. If it's your grandmother, your child, or your niece, or even your coworker, right? People are covered by this. It is a huge part of our healthcare system. It is a huge part of what keeps our hospitals going, and particularly the sort of the inner city, some of the poor inner city ones, and as we've heard, the rural ones. It is so. And if there's very, very good polling at KFF about Medicaid around the last 3 years, and you've really seen a shift from something that was considered for others. It was welfare. It was for other people. And it is really looked at now, including by close to half of Republicans. So the last number I saw was, I think, around 45%. It is really looked at as healthcare, not welfare. And that has changed the whole political dynamic. It was not easy for the Republicans to get this through. Right. And they didn't do some of the even more radical things that they had talked about. They didn't turn it into a block grant. They didn't turn it into a protected cap. They've been trying to do that since the 1980s. They couldn't really do these really, really radical. They didn't blow up what we call the FMAP, the matching, for the ACA expansion, which certainly brought a lot of new people in all but 10 states now. And that has a constituency, that's sort of working class people who were not eligible for before and aren't eligible now. There are about a dozen or so states that have what they call a trigger. If the federal government lowered its share, expansion would have been repealed automatically. You should keep an eye, because there are some conservative lawmakers who want to define that quite broadly, and who are going to argue that because there's some new costs that are going to fall on the states to set up verification systems and so forth, that the FMAP has changed. So some of the conservative states with triggers, watch your state, because you might find lawmakers trying to have creative definitions of what's setting off the trigger. Anyone on this webinar from North Carolina knows that you have an unusual trigger, and the expansion's probably going to, and unless the state government steps in, expansion's probably going to be unwound in North Carolina. There are a lot of measures for how popular it is. A couple of years ago, as you all recall, a lot of the Republican state legislatures did not want to expand, even though the federal government was picking up 90% of the cost. They decided, well, the politics, this was from the Democrats, it was Obamacare, and we're going to say no to this money from the federal government and not do it. And what happened in quite a few states, there were referendum, there were voter and ballot initiatives, and they won except even in Florida, they won, but there's a higher threshold for being enacted in Florida. And every other state, they won big in places like, Utah and Idaho. It's very popular. So, I think we really have to sort of watch how this plays out. You saw Josh Hawley, who, from Senator from Missouri, who was jumping up and down and screaming, for all year, I'm a populist, I can't vote for Medicaid cuts. And then he voted for the Medicaid cuts. And like 2 days later, he put in a bill saying we need to repeal the Medicaid cuts. I voted because the tax cuts were important too. But now, Kathy noted that, all the pay-fors for Obamacare, the mandate is gone, the Cadillac tax is gone, the insurance tax is gone. A whole lot of things that were paying for it that people were on the medical device tax, they all dropped. So is this going to stay as is? I don't see an opening right now for changing it. I think it's like they went through, it was too traumatic getting it through for them. As you probably know, they are talking, some lawmakers are talking about changing the ACA portion of it. There is some talk about extending the subsidies that would otherwise expire in a couple of months. Too soon to know whether that happens, but it's a topic to watch. I think that the other thing about Medicaid is understanding it's popular, not just because it covers a lot of people, but what it covers. It covers, it's the single biggest source of opioid treatment and abuse treatment, substance abuse treatment. It is the single biggest payer in this country for that treatment, and that is now endangered. It is the single biggest, it covers 40% of births, 40. 4 out of 10 kids are born on Medicaid, or their moms are on Medicaid. It covers, it's the biggest payer of long-term care and nursing home care. Now, they're not going into nursing homes and saying you're not eligible. It's what Kathy was talking about. There's certain populations that states have to cover. They didn't change that eligibility on the surface. They changed a lot of stuff around it, which Kristen was talking about. So if grandma's qualifies for a nursing home, she still qualifies for a nursing home, but the nursing home workplace mandates were repealed or thrown out in this bill. And since states, I think and there's some rules about how much the spouse, their partner that's not in the nursing home, in the family home, they change the values. Like the threshold for what qualifies, what you're allowed to keep. So there are things around the edge of the nursing home population. And there are other people over the last, I don't know, Kathy can tell you how many years, but I don't know, a number of years, there's been a lot more care in the community, home and community-based care. I would say it's probably 15 to 20 years. It's been growing and growing. States have a lot of flexibility on how they do that. And many, many people don't want to be in a nursing home. They want home and community-based care. But because states are going to have, so it's not that Congress said you can't do that or we're cutting that, but because they changed the provider taxes, which is how states raise money for Medicaid, there's going to be less money. And what Kristen just said, Michigan's already in this process. Watch your state legislatures, because they're going to have less money because of the provider tax. And over the next year, you're going to see big budget fights between now and the 2026 elections. Most states, it'll start in February, or in January, February, March. The different states have different schedules. So that is still not, they're not throwing people out of nursing homes per se. This is mostly the 64 and under, or the able-bodied under 64 population is the biggest demographic group affected by the law. But there are going to be changes. So, I think that it's the politics of this, we are a closely divided country. We're still going to be a closely divided country next year. In a really deep red state, will this change it? I would probably not, but losing health insurance is a really big deal. It is way, way, way harder to take away coverage than it is to give coverage. I can only think of one example, in sort of since since the creation of Medicare. I can only think of one time when they repealed a benefit, and that was the Catastrophic Care Act in the late 1989, 1990. They repealed that. That was for creating an out-of-pocket max for catastrophic care in Medicare. It was really poorly designed. Everybody hated it. It was repealed, and it was enacted and taken away very quickly. But think about Trump's first term. He thought he had, and the Republicans thought they had, a mandate to repeal the Affordable Care Act. They spent the better part of a year on it. They failed. And one reason I think they failed, particularly in the Senate, less so in the House. I mean, we all remember the fight about, pre-existing conditions and how important they were. But go back and think about the Senate and what happened in the Senate. And one of the most vivid memories I have, it was those little kids, they called them littlest lobbyists, and they were disabled children on Medicaid. And I think that those little kids and their families were part of what prevented the ACA from being repealed. When John McCain famously did the thumbs down, he said, this is bad for Arizona's Medicaid. So it's a very, very salient, where I started, 80 million people. And the people touched by those 80 million people is an awful lot of us. Whether you have a disabled family member, whether you have somebody getting long-term care, or in the nursing home or in the community, a lot of Americans are touched by this, and there's no easy replacement for it. So I think that watching, and it's going to change from state to state because the budget battles will go from state to state, and it's going to look different. There's a million stories you can write about this. I've been writing about Medicaid for many, many years, and I never get bored because there's always a new twist. And there's an extra political twist to it, is that a lot of people on Medicaid, this 80 million, are actually Trump voters because of the realignment of the parties and who considers himself a Republican and who considers it. A lot of the working class people who are covered by expansion or traditional Medicaid, but particularly the expansion population and the lower and some of the ACA subsidy people as well, they're Republican voters. So this is something that I've had Republicans tell me, what are we doing to our base? So again, it'll play out differently in it's going to play out differently in Texas, where they didn't expand to, a Democratic state like Massachusetts is going to keep spending money on healthcare. But there's going to be, and it's not just rural hospitals. It's going to be, substance abuse clinics. It's going to be federally qualified health centers. It's going to be anything that treats low-income people is going to have to struggle. So I'm going to sort of stop talking.
Joanne, thank you very much. That was a great presentation, and I agree that it's very hard to take away stuff that people like. And so when you say taking away coverage is hard, do you mean because of the pushback that will happen at the ballot box?
I think a lot of things. I mean, it's going to affect all of us, right? Because, if I'm not on Medicaid, but I live either in a city, in an urban community where a safety net hospital is going to be cutting back services, whether it's the, cardiac or orthopedics or, closing an urgent care center or labor and delivery is a big one, particularly in, there are maternity. If I live in a community where the providers are going to have to cut back on services, I will be affected whether or not I'm on Medicaid. So that's one area. Absolute, people who they didn't say you are no longer eligible for Medicaid. They create, so the Republicans saying we didn't cut it, we just tightened it up. And that shift in language is really important because remember I said people see it as healthcare, not welfare. But how are the Republicans talking about it? Waste, fraud, and abuse. People who should be, they're trying to change, they're trying to fight back. If we all think that these people are the only people who are going to be affected are people who are fraud, right? The bad guys, the people who shouldn't be on in the first place, it makes it less politically salient or politically popular. So they know what they're doing. They're talking about it as a fraud program. And they're not saying, okay, Sally, you can't be on Medicaid anymore. They're saying, Sally, you need to verify that you're eligible twice a year instead of once a year. And if you're working, you need to prove it. And if you're not working, you have to show that you're getting a job. It does count community activities, volunteer work, some other things. It's not only employment, but Arkansas and Georgia that have had work requirements. It's not that people weren't working. It's that the verification system was so broken, people lost coverage even though they were working. So it's like remember the Obamacare website? It was sort of a miniature version of that in all 50 states, trying to get these verification. And do people have access to internet? Do they have access to broadband, et cetera, et cetera, et cetera, in rural areas in particular? So it's not saying, okay, Sally, you can't have Medicaid anymore, but it's like, Sally, if you don't go through all these steps, to keep it, then you will lose it, and that's because you're just fraudulent anyway. So there's a difference.
Plus, it's hard for them. It's difficult for those people because so many Americans are gig workers, kind of like freelance journalists, right? Like if I was supposed to prove that I worked 40 hours, well, how would I do that? I got, I bill my clients and they send me a check and it doesn't show hours.
It's 80 hours a month. It's not full time. It doesn't have to be full time.
Right, 80 hours a month. Yeah, thank you. I also wanted to ask, what pitfalls should journalists avoid when translating complex Medicare policy into accessible stories for general audiences? I think Kristen did a good job bringing that stuff home. Is that the kind of story people should be looking to do with, real Americans who might suffer?
I think stories like this, finding people who are affected, makes it less pure. There's a lot of jargon in healthcare. We all know that. And you learn how to try to come up with, we've all found our own synonyms or analogies, a way of explaining things that you're not. Except, there's some things that no one will ever understand, like ERISA, but let's not go there. But a human face helps. And you know, as Kristen said, you can't just sort of walk in. I mean, first of all, HIPAA rules, you can't walk into a clinic. I usually try to go through a trusted intermediary, which is her approach as well. You call a social services agency, you call a provider, you call you know, some kind of a, you know, long-term care community program, whatever, that someone who knows you, because that trust can be transferred. If someone trusts you, they can often, I mean, getting someone on the street, you know, like, you look poor,
Yeah,
you talk to
right.
me, that's not going to work, right? But
No, right.
that's the trusted intermediary. I read about aging and end of life and caregiving as well. I mean, you know, that's how I do it. I get somebody to introduce us.
I think another angle that I forgot to mention before, just on the story part, is trying to find some examples of people who were working, weren't able to document their work, lost their coverage, and then couldn't work anymore because they lost the ability to take the medication that they need that allows them to, you know, manage a chronic condition so that they can work. And there've been many really good studies of Medicaid expansion that have documented that it's increased people's labor force participation, not surprisingly, because when people are healthy, they can work. So I feel quite certain that this policy is going to reduce labor force participation. And that would be a great story to tell, you know, to find an example of someone who ends up working less because they weren't able to jump through all the hoops, lost their coverage, and then don't feel well enough to work anymore and don't have coverage. And I'm sure, unfortunately, I think that's going to be a pretty common story.
Yeah, that's a really good point, Kathy. And there was a study came out earlier this year that showed that Medicaid provides a return on investment for the states because of the increased labor force participation. So more people working provides more tax benefits for the states. Do you agree, or what do you think about that?
Well, there've been a lot of studies that show there's a fiscal benefit for states because it, you know, there's more money
Right.
coming into health providers they can hire and stuff. But I know that the state of Ohio did a very high quality study of the impact of expansion. And one of the things that it took away from that study was that participants reported that, hey, now that I don't have headaches all the time, I can work more hours, or I've been able to take a medication for my eczema or whatever, and I'm, you know, my labor force participation is increasing, and they hailed that as one of the benefits of expanding Medicaid. But then, you know, their whole delegation voted, you know, for this bill. And so I think that people, you know, unfortunately, the things that we've been talking about are not secrets, and the people that voted for this legislation know that, you know, it's not going to increase work, and it's going to save money by, you know, by people falling through the cracks.
The other
Right.
thing,
Do you know where we could get that report? I'm sorry, Joanne. Let me
Go
just
ahead.
ask that one question and we'll come back to you. Do you know, is it a recent state of
No,
Ohio
it was
report?
like right when expansion, you know, they
Okay.
expanded in
Yeah.
like 2015, and they hired RTI to do a
Okay. Yeah.
survey. It's findable. They've made it a little bit harder to find, but it's findable.
Okay, thank you. Joanne, you were going to make a comment there?
I think that most people on this webinar probably are familiar with the term social determinants of health or social drivers of health, which is things like housing and access to food and other social transportation to get to the doctor, utility, things like that, you know, your electric bill. These are things that worsen health outcomes. Medicaid has had the flexibility. It depends, it's state to state. It depends on what state policies. It depends on Medicaid waivers. This is not, it depends on what a health plan, the managed care plans want to do in any given community. But to overstate it, Medicaid is helping with social determinants of health. And that is also something that you may see, well, the current administration is a little more skeptical of that, first of all, but you may see that these sort of ancillary programs to help somebody, you know, get to the clinic for their checkup, because, you know, there's not great public transportation. You're dependent on somebody getting you a ride, or you have to drum up the money for an Uber, or you have to depend, you know, your church might have somebody, and then it gets hard to keep asking people for help. You know, these things that aren't technically health dollars. I don't think we yet know, and Kathy might know more about this than I do, how much restriction, but states can certainly choose to not do it as much. I'm not exactly sure where the federal boundary.
Yeah, well, there's sort of a vibe shift on all that stuff now, and there's going to be, you know, much less approval of waiver applications to provide those.
They've said they're going to review current waivers as well.
Yeah.
We don't yet know, but that movement, I think, is it may not go away, but I think you'll be seeing less dollars spent on those things because states are going to have less dollars.
For sure.
Let me just ask Kristen a question. You and I, when we spoke the other day, mentioned that one of the repercussions of the bill would be consolidation of hospitals. Now, we've already seen a lot of consolidation of hospitals and how that can hurt an economy in a local area, how it hurts some facilities have to close, others, don't offer as many services as they once did. And the trade-offs people mentioned that when they interviewed the chief of strategy for Harrison Memorial. And do you expect to see that as well, Kristen?
I think so. We've already seen that trend happening in Michigan and I know across the country. I thought there might be some regulation, there might be some oversight, especially on some of the larger ones that happened here in Michigan. And that did not happen. Even the Biden administration did not step in and regulate or stop any of these consolidations. So I think especially now in this administration, we're not going to see, denials of these deals going through. And I think as these small, rural, independent hospitals continue to struggle, they might become attractive to larger hospital systems that can gobble them up and expand their reach. And they can, save the money and have better savings because they are a larger hospital system. They can, do supply chain savings by buying in bulk and that sort of thing. And that's how they can keep those smaller places open.
Thank you. Did you want to add something to that, Kathy?
No, I mean, I think that's a trend that's been really happening since the ACA was passed. There's been so much consolidation in healthcare on the provider side and the insurer side. And, I can see this bill by creating a lot of vulnerability in hospitals, just kind of accelerating that. It's not my biggest worry right now, but it certainly is something that it wouldn't surprise me at all to see that continue.
Is there anything that we haven't talked about? We have a few more minutes. I'm told 5 more minutes. That either Joanne or Kristen or you want to add, Kathy?
Joe, I think we've got a couple of questions from
thank you.
Our audience members. So
Thanks,
I will, I'll jump in here and ask a couple of those, and that would be great. So, Ariel Hart, actually with the Atlanta Journal-Constitution, said that Kathy mentioned the Rural Hospital Fund, and their local version of the AHCA is telling her that nursing homes can apply as well. Is that accurate?
I think states apply, and then states can distribute the money to different, and they don't have to give it all to hospitals. They can distribute it to different institutions throughout the state. And I believe that the way it's currently set up is that half of the 50 billion will be sort of given out equally to states if they complete an approved application. And no one knows quite exactly what that means. And it sort of sounds like it has no bearing on the size of the state or how many, how rural the state is. But I mean, at least that's sort of the straight read of it. And then the other half of the 25 billion, there's quite a bit of discretion in how CMS will dole it out to states. And then states in turn have some discretion in how they spread it out to different facilities that will be asking for it. But there are some requirements that states need to make a case that the funds will be used for certain things, and it's pretty broad. It includes things like managing chronic conditions, and there are a lot of different things that states can use the funds for. So they don't have to only go to rural hospitals, but I think it's the criteria that CMS will use in meeting out that other 25 billion that's not clear.
Yeah, we all call it the, including me, we all are calling it the Rural Hospital Fund. It's actually the Rural Health Fund.
It's the Rural Health Fund.
Right. And I'm not sure why we all, because I think the political conversation was about rural hospitals closing.
Yeah.
But it can be used for.
And I think even for some things that aren't necessarily rural, for example, if New Jersey or Rhode Island is getting any of this money, which it seems like they might.
And it seems like naming across the board on all things Medicaid is there's arbitrary names for everything, it seems like. And that's kind of leads us to our last question here that Pat talked about saying that, only 13 of 50 states call their Medicaid programs even Medicaid. There are other names for it.
Badger care.
Right. And
Yeah,
so-
Badger Care, that's right, yeah.
Yeah,
That's
and
a good
so
one,
maybe
yeah.
that, I guess that might be done intentionally to protect patients' dignity, but as Joanne said, it's less now. Medicare is healthcare, not welfare, and so it now kind of presents this problem that when recipients don't know, they don't even know that they're receiving Medicaid benefits, and now what's on the chopping block is something that is part of that package. Are we in agreement there?
Yeah, I mean, it's just complexity piled upon complexity, and you have people walking around with a card that might have an MCO on it, and then they, their healthcare's from Aetna or whatever, and they don't even really know that's Medicaid. So it's very hard to communicate with enrollees, especially when there's so much bouncing around between Marketplace and Medicaid. And we learned with redetermination just how hard it was to communicate to people that they needed to do things. And that's kind of where that harm reduction part comes in, is everyone's thinking they can we come up with a better mousetrap so that we don't, have all these problems with communication and setting up easy ways for people to share information that's super relevant. And I don't think that we had too much success with redetermination. I mean, honestly, even states that tried really hard had lots of trouble. So I think it'll be but there's a lot of energy around trying to do a better job. So that'll be a great storyline in every state to see what kinds of changes take place with eligibility and enrollment systems.
That was,
And I think that makes things,
right.
yeah.
That was the question I emailed a source after the bill paid. How many do we know that people even know they're on Medicaid? Because Badger Care and
Right.
Cal, was it Medi-Cal, and
Mm-hmm.
Right.
Apple Care in Washington State, there are all these names. So do people even realize, and how many realize? And there's no data, but it's a very good question. As you do your reporting and you talk to real people, do they know what they have?
And we know from some of the high quality federal surveys that actually ask people what they're enrolled in, and then make them get their card and look that there's a lot of a very high error rate when people self-report their coverage status.
Mm.
That's a great place to wrap too, to think about even how the most basic stories are ever more important. They don't have to be so complex, or, we might think that we're not advancing the story by just a simple question about, is this a Medicaid program or not, right? And that is. We appreciate all of your time, all of our attendees, and thank you again, Kathy, Joanne, Kristen, for your insights today.
Yes.
Everybody who tuned in. And if you're looking for more sources and possible story ideas, please also consider attending or tuning in to the AHCJ's Rural Health Workshop on August 21st. Again, it's in Atlanta, but it's a one-day event. It's also going to be streamed live, and that'll help us all understand the implications of the recent bill, other changes to federal policy that have occurred since January. But if you joined us late, you can find a recording of this webinar at healthjournalism.org. We will have Kathy's sides there in a few hours, but otherwise, all the best and good luck on your reporting. Have a great rest of your day.
Thanks, Lara.
Thanks all. Bye, everybody.